So here's some more procedures that we can do with GI studies. An ultrasound will visualize gallstones in the dilated common bile duct. So you can't just do a plain ultrasound. An abdominal x-ray or CT scan will look at calcified gallstones in an enlarged gallbladder. A hepatobiliary scan, also known as a HIDA scan, is very popular. It assesses the patency of the biliary duct system after you inject IV injection of contrast. So they'll inject the contrast or the IV dye, and then they'll take pictures to see how well the ducts are, if they're obstructed or not. The ERCP, the endoscopic retrograde cholangiopancreatography, is the drawing that I showed you of how they do that with the scope, and it goes down to the common bile duct through the duodenum. Sometimes they can make a cut where the bile duct opens into the duodenum. They make a cut, and that's called a sphincterotomy, and that helps pull the gallstones out. A percutaneous transhepatic cholangiography means we're going to poke through the skin on the outside through the liver and inject dye into the vessels that way. So if you remember it with the word parts, so the percutaneous, we're going to poke through the hepatic or the liver, okay, to take pictures of the gallbladder that way. This one requires a radiologist to be involved, and they will inject the contrast with a needle, and the gallbladder ducts can be seen that way, and they'll take the pictures that way. Sometimes they can do the ERCP and the PTC together, especially if they're having a lot of difficulty doing either or, and they can't get the structures visualized. They'll do them together, and it's called a rendezvous. Very intense, special procedure. A lot of fun to go to, but it does create risk for the patient because you are poking through a needle and you're putting a scope down their esophagus, so it's just difficult. But the nurse's job here is just to monitor mainly. So the ERCP, they also will get the iodine, and we're going to inject iodine to look at the structures. So it's the same one I already told you about. With this one, since we'll probably do a sphincterotomy as well, and there is a chance for bleeding, we want to check their coags, so their labs, NPO. They may be sedated with moderate sedation, which is like conscious sedation, so IV fentanyl and Versed. They may need to change positions frequently. Now this is textbook, but now in real life they put everyone under general anesthesia for this procedure now, and that's because the patient population has become so much more complex and sicker. It's almost safer to put them under general so they can manage their airway, because the ERCP scope is the same thing as an EGD scope, except it's a little bigger and it's hard to manage the airway, and you never know if this procedure will take 1 minute or if it will take 2 hours. We just don't know. So it's safest for the patient to have a secure airway, so we'll intubate them. But for textbook purposes and for NCLEX purposes, this is considered a moderate sedation or light sedation procedure, and the patient may need to change positions frequently. So we'll inject the dye. The physician will inject the dye. They'll take pictures under fluoro. And for post-procedure, is post-sedation, monitor for complications, which would be increased pain, fever for infection, and just follow whatever orders that the doctor has. Make sure you check for iodine allergies.